Good morning. I hope you can hear me. Can someone say?
Yes, we can hear you, Dr.
Right. Thank you very much. So I would like to begin by thanking the Candy Society of Medicine and the Sri Lanka College of Microbiologists for arranging this symposium. I regret very much not being able to be there in person, but I hope you will forgive me given the current situation in the country. So the topic given to me today is allergy and anaphylaxis to antimicrobials. But I would like to take you through the other sort of immune-mediated reactions that can occur as well. So first of all, we'll have a look at the nomenclature and classification of these terms: adverse drug reactions, drug hypersensitivity, drug allergy. So there are so many terms that are used to describe drug allergy, and most of these overlap, and sometimes we don't know what when we hear the term what exactly is meant by that particular term. So adverse drug reaction, it is defined as a harmful or unintended reaction to drugs that occur at doses used for prevention, diagnosis or treatment. So this is a fairly common thing to happen. It can affect between 15 to 25% of patients who are prescribed medicine. In 7 to 13% of them, they may experience serious reactions. And it is also said that about slightly over 3% of all hospital admissions are due to adverse drug reactions. And if you take patients who are receiving inpatient care, in about 10 to 20% of patients, the management can be complicated because of adverse drug reactions. So adverse drug reactions can be divided into type A and type B. However, now they are most of the time referred to as on-target and off-target effects. So type A ones are on-target effects, meaning that they are predictable reactions that are related to the known pharmacologic action of that particular drug. So it will occur in anyone who is given the drug, and it's generally dose-dependent. So examples would be side effects such as nephrotoxicity when you take aminoglycosides, drug interactions such as macrolides leading to increased blood levels of statins, and antibiotic-associated diarrhea, where antibiotics may kill the commensals and it might lead to Clostridium difficile infection. So type B reactions are unpredictable. They are also called off-target effects, because they are not related to the pharmacologic action of the drug, and it generally occurs in susceptible individuals. So it will not occur in just anyone who takes that particular drug. So under this comes drug hypersensitivity, that is allergy and anaphylaxis, drug intolerances such as tinnitus after aspirin, and some idiosyncratic reactions. So examples would be urticaria or angioedema following use of NSAIDs, or even exacerbation of respiratory diseases following non-steroidal anti-inflammatory drugs. So we will concentrate a little on this drug hypersensitivity reactions. So drug hypersensitivity reactions can again be divided into non-immunologically mediated hypersensitivity reactions and immunologically mediated hypersensitivity reactions. So your immunological mediated hypersensitivity reactions are generally either antibody mediated or pure T-cell mediated. So these kind of reactions generally retain immunologic memory, meaning when you continue to use the same medicine, symptoms can recur. So non-immunological mediated hypersensitivity reactions, examples would be cellular toxicity and disrupted physiology, non-immune cell receptor interactions, and also immune receptor interactions. Now this is very interesting area, this immune receptor interaction. I will talk about it a little later, but for the time being, these have an immunologic phenotype. So they appear quite similar to an allergic reaction, but generally they do not retain a memory. So that is the difference between most of these immunologically mediated hypersensitivity reactions and non-immunologically mediated hypersensitivity reactions. So when you see a patient, both patients might have symptoms of immunologically mediated reaction, but some of them might not retain memory. But if it's mediated by either antibody or pure T cells, then the immunologic memory is retained. So we will then see how we can divide these immunologically mediated hypersensitivity reactions further. So if we go back to our Gell and Coombs classification of hypersensitivity, if you can recall, there are main 4 types. 1 to 3 is generally considered to be due to antibodies, in the sense that type 1 is due to IgE, type 2 is due to either IgG and complement, type 3 is IgM or IgG and complement, or the combination of receptors. So this leads to deposition of immune complexes. And type 4 is generally due to T cells. Okay, so this again is the immunologically mediated drug hypersensitivity reactions, and type 1 to 3 is mainly due to antibodies, and type 4 is due to cells. So if you take IgE-mediated reactions, examples, patients can present with anaphylactic shock, angioedema, urticaria, bronchospasms, and so on. So generally these occur within 1 to 6 hours after you use the drug. When it comes to type 2 reactions, examples would be cytopenia, such as thrombocytopenia or anemia. There the symptoms generally occur within about 3 days, but they can start about 5 to 15 days after starting treatment as well. Type 3 reactions, or those that occur due to deposition of immune complexes, they clinically present with symptoms of serum sickness. They can present with urticaria or vasculitis, and these generally occur about 1 week after starting treatment. Now, if it's vasculitis, it can start very much later, such as about 3 weeks after you start treatment. So type 4 can be divided further into type 4A, 4B, 4C, and 4D. So generally, these can be either cutaneous symptoms alone, or there can be systemic involvement as well. So the time of onset can vary depending on what exactly is happening. So immune-mediated drug hypersensitivity is very important because it can account for about 20% of all adverse drug reactions. And when you consider the general population, about 8% of people in the general population may be affected by immune-mediated drug hypersensitivity. So the commonest presentation is cutaneous reaction. So they will present with either rash or urticaria or angioedema. So severe immediate allergies are quite infrequent. And you have to remember that antibiotics are the commonest cause of life-threatening immune-mediated drug reactions. So that is why we have to be very careful when it comes to using antibiotics. So clinically, we classify these hypersensitivity reactions into those that occur immediately, or reactions that take time to develop. So immediate drug hypersensitivity reactions occur within 1 hour after the last drug administration. So these are generally due to IgE, but non-IgE mechanisms are also there. Non-immediate drug hypersensitive reactions occur after 1 hour from the initial drug administration. So generally those that belong to Chell and Coombs type 2 to type 4 are in this group. So if you look at the diagram in the right hand side, you can see there can be immediate reactions that may sometimes appear a little after 1 hour, and there can be non-immediated reactions that are sort of accelerated and can occur a few hours early as well. Clinically, sometimes it might be there might be reactions that fall into the gray area as well. But this classification of immediate and non-immediate reactions is good enough for clinical management of patients in the acute situation. So we'll concentrate on how these IgE-mediated reactions occur. So generally, in any IgE-mediated reaction, you need to be exposed to the allergen first. So what happens when you get exposed is that there is activation of lymphocytes that is specific for that particular allergen. So it's a very specific thing. And this will lead to production of IgE antibodies. And these IgE antibodies will go and sit on mast cells. Mast cells have Fc receptors that has a high affinity for IgE antibodies. So whatever the IgE antibodies that are produced will be bound to these receptors on mast cells and maybe basophils as well. So if there is a second exposure to this particular allergen, there will be binding of that allergen to the IgE antibodies, and then there will be cross-linking of these receptors, and it will lead to activation of the cells. So following activation, there will be release of mediators from the mast cells. So as you can see, mast cells and basophils, they degranulate, releasing histamines, leukotrienes, prostaglandins, and platelet activating factors, which lead to vasodilatation, hives, edema, redness, itching, and so on. So what are these allergens in antimicrobials? So these allergens are largely described for beta-lactam antibiotics. So it can, these epitopes can be from the core beta-lactam ring or adjacent ring structures. So we all know that when it comes to beta-lactams, each beta-lactam has a beta-lactam ring, and there are side chains that make up the rest of the drug structure. So when the epitopes are to this core beta-lactam, there can be cross-reactivity between most of the beta-lactam antibiotics, whereas if it's to a particular ring structure, then the allergy is limited and it will be limited to beta-lactam antibiotics or any other antibiotic that has the same ring structure. So penicillin antibiotics or beta-lactam will not be directly allergenic, in the sense that there has to be some sort of a degradation inside the body, and whatever these products need to bind to serum and tissue protein to become a sort of a allergen that can be detected. Otherwise, these drug molecules are quite small, and they will not be detected by they are not big enough to produce an allergic reaction. So it has to be broken down inside the body. So after being metabolized, only these products bind to carrier proteins and then become truly allergenic. What are the clinical manifestations of IgE-mediated reactions? So most often, patients present with urticaria. They might present with angioedema, swelling of lips, periorbital edema, and so on. Conjunctivitis, rhinitis, bronchospasms, and also GI symptoms such as nausea, vomiting, diarrhea, and abdominal pain. And the most feared clinical presentation is anaphylaxis or anaphylactic shock. So anaphylaxis. We need to increase awareness of current concepts in assessment and management of anaphylaxis, because we need to prevent recurrences and we need to reduce unavoidable deaths and we need to improve allocation of resources. So the estimated mortality from drug allergy or anaphylaxis that is caused by drugs is about 0.05 to 0.5 million people per year. So you can see how that mounts up to with other anaphylaxis caused by food or insect venom. Clinical diagnosis of anaphylaxis. So when a patient comes to the emergency treatment unit, you need to quickly diagnose whether this is indeed anaphylaxis or not. So for that we use this clinical tool, and this is quite a good tool because it has a sensitivity of about 95% and a specificity of about 71%. So this sensitivity is very important because you don't want to miss any patient who has anaphylaxis. So you might overtreat patients because the specificity is around 70%, but the important thing is that you should not miss any patient. So earlier we used to talk about 3 clinical scenarios where we diagnose allergies. So the first one was where any patient who presents with skin manifestations, that is urticaria or angioedema or both, with one of these symptoms are related to airway circulation or GI symptoms. And then the second one was where the patient had an exposure to a possible allergen, and when they presented with 2 of these symptoms. So in that instance, the cutaneous manifestations was not essential for a diagnosis of anaphylaxis. And the third scenario was where there was a drop in blood pressure when a person was exposed to a known allergen. So the clinical diagnostic criteria has changed over the years a little. Now there are only 2 clinical criteria. So the first one is acute onset of an illness, minutes to several hours, with involvement of skin, mucosal tissue or both, and at least one of the following, that is airway breathing, respiratory compromise. So the patient should have dyspnea, wheeze, bronchospasm, stridor, reduced peak expiratory flow, hypoxemia. The second one is circulation compromise, reduction in blood pressure or associated symptoms of end-organ dysfunction such as incontinence. And the third one is severe gastrointestinal symptoms. So severe crampy abdominal pain, repetitive vomiting. Now this symptom is especially important if the exposure is to a non-food allergen. So sometimes especially in pediatric patients, after allergy to food, they develop allergy, and at the same time they develop a bit of abdominal pain and mild vomiting as well. So that might not be anaphylaxis, but if the same symptoms occur as a result of insect bite or or intravenous drug or something, then it becomes very important. So the second scenario where you clinically diagnose anaphylaxis is acute onset of hypotension or bronchospasm or laryngeal involvement after exposure to a known or highly probable allergen for that patient. So the exposure should have been minutes to several hours ago, and in this scenario you don't even need to have any typical skin involvement. So earlier classification didn't recognize where bronchospasms or laryngeal involvement occurred in isolation after exposure to a probable allergen for that person. But now in the current guideline, it is accepted. So this blood pressure varies depending on the age of the patient. So for infants and children, low systolic blood pressure or greater than 30% decrease in systolic blood pressure. And in adults, systolic blood pressure less than 90 millimeters of mercury or greater than 30% decrease from the person's baseline. So you have to remember now, objective respiratory signs in isolation following exposure to a known allergen is indicative of anaphylaxis, and you have to manage accordingly. Also, you have to remember that there are various factors and cofactors that influence anaphylaxis. So sometimes when these factors are there in association, patients who usually develop few urticaria patches here and there might present with anaphylaxis. So cofactors that amplify anaphylaxis are exercise, acute infection, emotional stress, disruption of routine, premenstrual status. And sometimes concurrent use of medicines, alcohol, or recreational drugs can also lead to severe reactions. And there are some concomitant diseases that might lead to occurrence of anaphylaxis as well. So I would not go into the management of anaphylaxis, but I would just like to briefly talk about two particular kinds of anaphylaxis. I think management of anaphylaxis will be done later. So refractory anaphylaxis, this means unresponsive anaphylaxis to treatment with at least 2 doses of minimum 0.3 milligram adrenaline, that is to adult patient. This is quite a rare occurrence and occurs in less than 0.5% of severe cases. So most of the patients who end up with refractory anaphylaxis had previous anaphylactic reactions, concomitant asthma, malignancy, or they had been on beta blockers. So they occur most frequently with antibiotics or radio contrast. So this refractory anaphylaxis is often fatal, although it's very rare. The other one is biphasic anaphylaxis. So there is now, when you treat anaphylaxis, the symptoms will go down and the patient will be perfectly all right, but there can be recurrence of anaphylaxis that occur 1 to 72 hours following the initial event. So this should be clinically differentiated from a reaction that does not fully respond to initial treatment. So to diagnose this, the initial episode should have been treated. So risk factors for this biphasic sort of reactions are severe anaphylaxis and or need for repeated doses of adrenaline. So half of these reactions occur within the first 6 to 12 hours. So that is why we say sometimes when patients come with severe anaphylaxis that you should observe them for a longer period. So how do you diagnose anaphylaxis in the laboratory? So a measurement of histamine would be an idea, but it is very difficult to measure because histamine has a very short half-life and it's very difficult to measure. So in place of histamine, we measure serum tryptase. So serum tryptase increases from about 15 minutes after the onset of the reaction and remains elevated for about 3 hours. And the levels peak between 1 to 2 hours after the onset. So this does not, if you check tryptase levels in all the patients who had anaphylaxis, some of them might have normal levels, but that does not exclude anaphylaxis. If it's positive, it will support the diagnosis, but if it's negative, then we cannot completely exclude. So ideally, when this tryptase level rises, it should fall to the baseline within 24 hours. So you need to take a second sample 24 hours from the first sample and send it across for tryptase level measurement as well. So in patients with mastocytosis, what happens is their tryptase levels remain elevated and even after 24 hours the levels will be the same. So to differentiate patients who have mastocytosis and a person who had anaphylaxis, you need to do this follow-up testing. So a rise is considered when there is over 1.2 times baseline tryptase level plus 2 nanogram per liter elevation of the tryptase level. So you can see the positive predictive value is quite high, whereas the negative predictive value is quite low. So that means you can detect anaphylaxis confidently, but you cannot exclude anaphylaxis with a normal report confidently. So what about the other immediate reactions? So these may resemble IgE-mediated reactions, but they may occur as a result of activation of complement system, contact and coagulation system, IgG, or activation of mast cells through receptors such as MRGPRX2 receptor. Now this receptor has become a very much talked about receptor in the recent past. So this people would have noticed this is the reaction you would see when a person is given vancomycin or fluoroquinolones. So clinically, you might think it is anaphylaxis, but if you consider the symptoms, the cutaneous symptoms will be very much prominent in this, and respiratory symptoms will be less, and cardiovascular symptoms will be even less. So if someone presents with, even after vancomycin, with a blood pressure drop and a lot of respiratory symptoms, you might consider it as IgE-mediated allergy or anaphylaxis rather than mast cell activation through MRGPRX2 receptors. So if it's due to this mast cell activation, slow infusion, and no pre-medication with antihistamines and or corticosteroids may prevent it recurring, which you can't do if it's true anaphylaxis. So what you're supposed to do is, when you use vancomycin and fluoroquinolones, try to use fever-associated drugs with similar activity. So how do you diagnose immunologically mediated adverse drug reactions? So first of all, we'll see why it is very important. So patients can continue to have these unverified antibiotic allergy labels. So if you take few diagnosis cards from several patients, you can see antibiotic allergy labels in most of them. Because we very much like to record allergies when we see the slightest clinical manifestation. So it is commonly, there can be misdiagnosis commonly in pediatric patients when they have infections with herpes viruses, streptococcus pyogenes, where it will lead to a rash, and it will be attributed to some drug that had been used at the time, most often an antibiotic. So sometimes these rashes can occur during viral infection due to drug infection interactions as well. So one example would be your amoxicillins or aminopenicillins and EBV infection. So sometimes even side effects gets noted as antibiotic allergy. And the commonest reason for pediatric patients developing urticaria is acute viral infection. So regardless of whether they are given antibiotics or any other medicine, they will develop urticaria during acute viral infection. So sometimes this might be noted as drug allergy in the diagnosis cards. Effect of antibiotic allergy labels. So what can happen if you falsely label someone as being allergic to an antibiotic? So there are various effects that can, there are for the patient, for the healthcare associated infections. Are my slides stuck?
Looks like yes, Dhanushka is stuck.
Now we can see your current slide.
Which one is it? Effect of antibiotic allergy labels, is it?
Yes.
Okay, I'll just continue. I don't know what to do about it. Sorry about that. I'll just continue. Okay. So what are the effects on patients? So what can happen is the patient may receive alternative antibiotics that are more broad spectrum, have a lower efficacy, or has increased side effects. So, say you label someone as being allergic to amoxicillin falsely, when they get an infection, they will avoid all commonly used beta-lactams and go to some hi-fi drug, which is more broad spectrum, but it might not treat the condition properly as well. So sometimes the drug that is indicated may be a beta-lactam, but because of this allergy label, the patient might be given an alternative drug. So what is the effect on healthcare associated infection? So there is a strong impact on development of Clostridium difficile infection due to beta-lactam alternative and surgical site infections due to inferior perioperative prophylaxis where they have avoided beta-lactam antibiotics. Now, most of these figures are for beta-lactam antibiotics because that has been the antibiotic that is most widely studied and also probably the most commonly used type of antibiotics. So what is the effect on antibiotic resistance? So there can be up to 14% increased prevalence of MRSA and 30% increased prevalence of vancomycin resistance in patients with penicillin allergy matched to those without. So we have to be very careful and we have to look at these allergy labels properly because there had been a UK report that predicted about 10 million people globally could die from antimicrobial resistance per year by 2050. So that means we have to remove these false labels and continue to use the simple antibiotics wherever possible. And antibiotic prescribing and stewardship programs now include penicillin allergy evaluation as a method to reclaim narrow spectrum beta-lactam antibiotic use. So how do you diagnose immediate reactions? So the history is very important. Now don't forget, whenever you document a patient as being allergic to an antibiotic, you have to give a complete history because afterwards the patient might forget and also the doctor will forget if it's not documented. So you have to say to which dose of the drug the reaction occurred, all the drugs that were used at that particular time, and the interval from the drug as well. The examination findings and maybe mast cell tryptase levels. So you can do a skin test or an intradermal test, which I'm sure Nadisha will explain in detail, and go to a drug challenge. There are fancy new tests called basophil activation testing that is used now mainly for research. Serum specific IgE tests are available, but the predictive values are not very good. So just a few words about non-immediate reactions. IgE-mediated reactions, cytopenias, as I said before, they can commonly occur as a result of penicillins, cephalosporins, sulfonamides, JAKs and rifampicin. So here again, history examination, targeted laboratory evaluation and sometimes skin biopsy is important. So they are treated with corticosteroids or other immunosuppressants or immunomediators, modulators. So if these occur, you are supposed to avoid the implicated drug or drugs and you have to use caution with use of same class and potentially cross-reactive drugs as well. Serum sickness or serum sickness-like reaction or type 3 hypersensitivity reactions. Generally, the patients present with fever, rash, arthralgia, and generally this is secondary to penicillin, amoxicillin, cefaclor, and cotrim use. So again, you can do a few investigations, but the history and examination remains very important. They're generally treated with antihistamines and corticosteroids, and again, you are supposed to avoid the implicated drugs and use caution with use of same class and potentially cross-reactive drugs. So cell-mediated ones can affect a single organ, such as in the case of acute interstitial nephritis, drug-induced liver injury. So they can lead to isolated cutaneous reactions. So sometimes patients may develop maculopapular rash, fixed drug eruptions, and contact dermatitis. Or sometimes they can be systemic or multi-system disease. So examples are drug reaction, eosinophilia, and systemic syndrome, or DRS, Abercrombie hypersensitivity, Stevens-Johnson, toxic epidermal necrosis, acute generalized eczematous pustulosis. So those systemic or multi-system diseases are quite severe ones where you can't even test the patient afterwards. So you have to rely on the history when you label these patients to have that particular condition, and probably you can do a biopsy sometimes to confirm the diagnosis as well. So how do you diagnose delayed reactions? Again, history, physical examination, and there are various diagnosis scores that are available to diagnose Stevens-Johnson syndrome, liver injury due to drugs, and so on. So you can use one of those scoring systems. If there is no systemic involvement, you can probably do a patch testing or a delayed intradermal test, and if it's negative, might even do a drug challenge. So there are a few patients who come with these multiple drug allergy syndromes. So they claim that they are allergic to all the drugs that they are prescribed. So this affects about 1 to 5% of patients seeking health care. So if you really look at these patients, there is a high incidence of depression, anxiety, and somatic illnesses in these patients. And also, whatever the symptoms that occur are rather subjective symptoms. But you can't, you have to always think that there could be underlying biological reason for these as well, such as histamine-reducing factors, inability to tolerate small chemicals, drug-induced interferon gamma release, or presence of pre-activated CD4 T cells. So sometimes this can be a very difficult condition to manage as well. So what should we do in the future? So I think all of us should have a universal drug allergy history tool aimed at improving allergy documentation and identifying patients. So what happens most of the time, what actually prevents us from confirming or excluding an allergy is the absence of a proper drug allergy history. So if there is a universal tool that is available that can improve diagnosis, then your evaluation programs, now we can't evaluate all the patients that complain that they are allergic to various antibiotics. So you should prioritize. So immunocompromised patients may require antibiotics often, so their problems should be sorted out, and also preoperative or actively infected patients should receive priority. So if there is a low risk according to history, they can be labeled directly or they may be rechallenged and the label can be taken off. And also you have to educate patients and general public just what exactly is meant by drug allergy. So there is a take-home message. So if you ask the following 3 questions from a patient who is said to be allergic to penicillin or cephalosporin, you might detect a true allergic patient. So the first question is, did the urticaria develop after the first dose versus subsequent doses? Did the urticaria develop within 1 hour of inciting dose? Did the urticaria resolve within 1 day of stopping the beta-lactam in question? So if the answer is yes to all 3 questions, then sensitivity and specificity is about 85%, and the positive predictive value is again around that much. So you can, depending on the answer, you can, if the answer is yes, you can refer the patient to specialized allergy diagnosis or management. So these are my references. Thank you.